So
Yes.
let's me start the next session, the last session for this morning, the endoscopic treatment for upper GI cancer. Please, Professor Kikuchi.
Yes. I will start. Yeah, next I will talk about the treatment. Yeah, therapeutic endoscopy for upper GI endoscopy. Yeah, first of all, we have to know the indication of endoscopic treatment. Yeah, we have to treat a lesion without lymph node metastasis. First of all, we have to know we should treat the lesion without risk of lymph node metastasis, and the lesion that could be resected in en bloc fashion. This is a very big indication for endoscopic treatment. This is the relationship between tumor invasion depth and lymph node metastasis of gastric cancer. Most of the intramucosal cancer has no risk of lymph node metastasis, and it can be indication for endoscopic treatment. But if the lesion is invading to the submucosal layer, and in the gastric cancer, sub-SM1 is defined as cancer, submucosal cancer less than 500 micrometer from the musculus mucosa. SM1 cancer has a possibility of the lymph node metastasis about less than 10%, and it can be indication for the endoscopic treatment. But if the cancer is invading to the deeper layer of the submucosal layer, the possibility of the lymph node metastasis is over 15%, and these patients should be treated by surgical operation with lymph node dissection. This is indication of ESD proposed by Japan Gastric Cancer Association guideline. This is absolute indication, but recently we can resect the lesion regardless of the tumor size or tumor location, and this green area is also indication. And recently in Japan, the indication of the endoscopic treatment is gradually increasing, expanding and expanding. This is the relationship between depth of the invasion and lymph node metastasis of the esophagus. Yeah, compared to the stomach, the percentage of the lymph node metastasis is a little bit higher. And if the lesion is limited to the lamina propria, the percentage of the lymph node metastasis is quite low, nearly 0%, and it is a good indication for the endoscopic treatment.
Professor Daisuke, excuse me, I would like to ask other, we have to wait for a while because some audience cannot see your slide right now.
Oh, really? You can't?
I can, but other audience.
Oh, other audience. Okay.
That they cannot see your slides, but we have to solve. Okay. Okay. Only 30 seconds. We have to check anyone else cannot see.
Okay.
Your slide. Okay.
Joan, can you see?
Yes,
okay.
we can see
most of those.
some of them.
Okay.
Yeah, some of them is just cannot see. I think it's maybe the internet connection of their
themselves.
Yes.
Okay. I think right now most of the audience can see your slide. You can continue. Sorry about interruption.
Okay.
Yeah, sorry. Please.
Sorry. Please continue. Thank you very much.
Yes, it's okay. It is a relationship between the invasion depth and lymph node metastasis of the esophagus. And as I told you, the cancer is limited to the lamina propria. The percentage of the lymph node metastasis is nearly 0%, and this cancer should be treated by endoscopically. But if the cancer is attaching to the muscularis mucosa or invading to the submucosal layer less than 200 micrometer from the muscularis mucosa. This cancer has a possibility of the lymph node metastasis about 10%. It is a relative indication for endoscopic treatment. But if the lesion is invading more than 200 micrometer, we call such cancer as SM2 cancer. The percentage of the lymph node metastasis is quite high. And these cancers have to be treated by surgical operation. In the EMR era, this lesion is located at the gastric angle. The lesion is about 10 millimeter in size. And after spraining injectocalmine, the lesion demarcation can be detected easily. After marking, we inject injectocalmine or normal saline to elevate the submucosal layer. And next, this is EMR cap method. And we make pre-looping and suck the lesion into the transparent food and snaring and resect. This is the EMR technique. This technique is quite easy, and the procedure time is quite short, and it's very good technique. And this lesion, fortunately, resected in en bloc fashion without surgical is negative for resection. Complete resection was achieved. Well differentiated adenocarcinoma, 10 millimeter in size and intramucosal cancer, and it is curative resection. But sometimes we experience these cases. This case is a little bit larger compared to the previous one. After spraining injectocalmine, the tumor border is quite clear. After making marking dot very close to the lesion and snaring, but unfortunately, en bloc resection cannot be possible, and the piecemeal 3 fragment resection was done. In this situation, we have to reconstruct the specimen. And the lesion, the cancer, is completely divided into 2 parts. And this is a report from our hospital. For early gastric cancer, we perform 300 lesions for EMR procedure. About 60% of the lesion can be treated by complete resection. But about 40% is incomplete resection. Incomplete resection means piecemeal resection or margin positive resection. Of them, about 10% of the cases, we experience the local recurrence. It is quite severe, serious problem. This is a report about the local recurrence after EMR procedure. Highest report is about 40%. Totally, I think about 10 to 15% of the recurrence were reported after EMR procedure for early gastric cancer. We evaluated the utility of the ESD according to the size. According to the size, the EMR en bloc resection rate is significantly decreasing according to the size. If the lesion is quite small, less than 5 millimeter, the complete resection rate of the EMR is quite high. But the size is increasing, the complete resection rate is decreasing significantly. And if the lesion is more than 20 millimeter, the complete resection is impossible. However, in ESD procedure, the complete resection can be achieved over 90%. It is significantly different. Yes, advantage of ESD is high en bloc resection rate. And after en bloc resection, we can evaluate the precise pathological diagnosis. This is a big advantage for ESD procedure. On the other hand, Disadvantage of the ESD is high complication rates such as bleeding and perforation, and long procedure time, and sometimes cost is very big problem. So, agenda. This is my agenda. First, I will talk about the basic strategy of the ESD, especially for the gastric ESD. And next, how to manage the technical difficulty in the gastric ESD. First of all, we have to know what kind of device is necessary in ESD. There are many types of therapeutic endoscopy. In gastric ESD, we usually use two multi-bending scope, two-channel multi-bending scope, or 290 T scope. Both scopes have water jet function. In ESD procedure, water jet function is essential to keep the clear endoscopic visual field. Two-channel M scope, multi-bending scope, is a unique scope. There are two bending portions. So this function is very useful, helpful to approach the region located at the lesser curvature of the angle or gastric cavity. In this situation, sometimes it is a little bit difficult to approach to the region using single bending normal endoscope. We can control the distance to the region finely using second bending portion, but this endoscope is a little bit heavy and big diameter. So if the lumen is narrow, such as esophagus, maneuverability of the endoscopy may be poor. So in this situation, we use a normal conventional endoscope. Second is ESD knife. In Japan, there are so many types of ESD knives. We can categorize the endoscopic knife into three types. One type is like a dual knife, and the second type is IT knife, and the last type is a scissors type. In each device, there are advantage and disadvantage. I think you should master one device first. After you get experience more than 30 ESD cases, and if you feel some difficulty in ESD procedure, please change to another devices. And before you change the another devices, please check and study how to use it. And please check the ideal situation of high frequency equipment. Next, you should master the setting of high frequency equipment. In this presentation, I will talk about the BIOS 300T setting. And the injection needle and injection solution, transparent food, clip. This device is necessary for ESD. Especially injection is very important for endoscopic procedure. For injection needle, the length of the needle is important. I like 2 mm from the tip of the sheath. Mucosal layer of the stomach is a little bit thicker compared to the esophagus and the colon. And next, injection solution. Usually, we use glycerol. Glycerol solution is used originally for the brain edema. The osmolality of this solution is high, and there is no tissue damage. And I added small amount of the indigo calamine to visualize the submucosal layer well. And this coloration is the ideal situation for me. If glycerol is not available for you, normal saline is okay. Do not use glucose because of the tissue damage. For the region with fibrosis, mucosal elevation after injection is sometimes poor. In this situation, hyaluronic acid is useful. And the ESD procedure, I think, how to use transparent food is quite important. This is the SD food, short SD food. I like this food sometimes. Usually, I use normal transparent food, but if I feel some difficulty, especially to enter to the submucosal space, I change the transparent food to the short SD food. This food is the tip of the this transparent food is tapering, and it is useful to enter to the submucosal space. And sometimes we use clip, not only to the muscle damage, but also to the clip and line method. Sometimes we use clip and line method to elevate the lesion. I would like to show you one case, one representative case. First of all, we have to diagnose the tumor border. Before the ESD procedure, the diagnosis of the tumor border is important. Maybe in Japan, most of the doctors use indigo carmine and NBI magnification before endoscopic treatment. If the tumor border is clear, like this region, I make marking dot about 5 mm outside of the region, like this. And I added the additional marking dot at the oral side, like this. This additional marking dot is helpful for comparison between endoscopic diagnosis and pathological diagnosis after resection. And I use soft coagulation mode, effect 450 watt in the marking. Next, injection. Injection point is 5 mm outside of the marking dot. Sometimes we lost the marking dot during the ESD procedure. And this injection point is second marking. So please inject 5 mm outside of the marking dot. Don't inject inside of the marking dot. And we make incision at the anal site first. In anal site incision, the depth of incision is important. We make incision as deep as possible, little by little. If anal incision is shallow, sometimes we dissect over the anal incision. And next, we make circumferential incision. And during dissection, I think there are 2 phases of dissection, early phase and late phase. Early phase of the dissection means before entering the submucosal space. In this situation, please use the lower part of the transparent food. And please use the transparent food to push down the normal mucosa, like this. And please dissect 1/3 bottom of the submucosal layer. And this is the late phase of the dissection. Late phase of the dissection means after entering the submucosal space. In this situation, please use the upper part of the transparent food. And you should use the food to pull up the specimen. And the submucosal layer is very clearly visualized. And please dissect about 1/3 bottom of the submucosal layer. And the region can be resected in block fashion without any complication. And this is resected specimen. And this is the additional marking dot. So this area is the oral area. And this additional marking dot is helpful during the comparison between endoscopic diagnosis and pathological diagnosis. I would like to show you technical difficulty in gastric ESD. Maybe in gastric ESD, most of the lesion can be resected in en bloc fashion by ESD procedure recently. But I think in gastric ESD, fibrosis and intraoperative bleeding, these point is a technical determinant for ESD procedure in the stomach. This is the representative cases with fibrotic lesion. Yeah, this region is here, slightly reddish area. And after spraining angiocarmine, the tumor border is not so clear. But in this situation, using NBI, there is a demarcation line here, and the microstructure pattern is a little bit irregular, and we can make diagnosis using NBI. And we make marking dot. But at the anal side of the lesion, the fold convergence is existing, and we suspect here is fibrotic. And we use EUS, and according to EUS finding, there is a fibrotic. In fibrotic region, first of all, as I told you, prediction is important. Oh. For prediction of the fibrosis, as I told you, EUS is useful. So sometimes we do EUS, miniature probe EUS, using 20 megahertz before ESD procedure. In this case, we suspect here is fibrosis. And after injection, here, the submucosal elevation is quite poor. In this situation, please make incision a little bit far from the non-elevated area. To enter to the submucosal space is important in this situation. If you make incision very close to the fibrotic tissue, it is very difficult to enter to the submucosal space. And if you suspect the fibrotic tissue during the ESD procedure, please make incision a little bit far from the fibrosis. And I make incision a little bit far from the marking dot, like this. And after making circumferential incision, sometimes we use clip and line method. I put clip here and pull back to the oral side. This method is proposed by Professor Oyama. And after putting the specimen like this, the dissection layer, it's very severe fibrosis, can be detected very clearly. And it is very easy to dissect like this. In this situation, please check from the distance and check from edge to edge and dissect here. And en bloc resection can be achieved. And I think intraoperative bleeding is the most technical determinant for gastric ESD. This region is here, very small region, but the region is located at the gastric greater curvature of the upper gastric body. Yeah, according to the NBI magnification, tumor border is relatively clear. And yeah, using angiocarmine, lesion can be recognized here. And we making marking dot. yeah, we can resect in a block fashion. But in this situation, intraoperative bleeding is very important. We reported the utility of EUS for prediction of intraoperative bleeding. Yeah, for example, this is the lesion. Before ESD procedure, we do EUS, and we can detect hypoechoic area like this in the submucosal layer. In this situation, during the submucosal dissection, we sometimes encounter such thick blood vessel. And if you find such lesion, the possibility of the intraoperative bleeding is high. So please be careful during the dissection. But in case of this case, there is no blood vessel in the submucosal space. In this case, during the dissection, there is no blood vessel, and there is no intraoperative bleeding, and easy procedure. And there are so many blood vessels in greater curvature of the middle and upper greater curvature area. And most blood vessel is existing in the superficial layer of the submucosa. So please make incision as shallow as possible, like this. And next, it is important to detect the submucosal, it is important to detect the blood vessel in the superficial layer of the submucosa. And don't damage the blood vessel is important. And after you detect the blood vessel, please coagulate using coagulospan before the cutting. So there is no bleeding, and there is no many blood vessel in deeper layer of the submucosa. So please be careful during the dissection in the superficial layer of the submucosa, and please enter to the deeper layer of the submucosa as soon as possible. It is very big point for gastric ESD. If you have no or little experience of ESD, please start ESD for easy location. Lesion at the greater curvature of the gastric antrum or lower gastric body. This area is the easiest location. Because endoscopic maneuverability is quite stable, and there is no blood vessel in the submucosal layer. And maybe this location is the first location for beginner. And next is a lesser curvature of the gastric antrum or lower and middle gastric body. This is the second location. In the gastric angle, the direction of the muscle layer is changing from the oral side and the anal side. For the beginner, this situation is sometimes a little bit difficult. And sometimes in the gastric angle, there is a fibrosis of the gastric ulcer. And in this situation, sometimes it is very difficult to achieve the embryonic resection using ESD procedure for beginner. And the final is the greater curvature of the upper gastric body and fornix. Greater curvature of the upper gastric body, there are so many blood vessels, and the submucosal layer is so fatty. And sometimes the lesion is under the gravity. It is a very difficult situation. And fornix, the wall thickness of the gastric wall thickness is very thin in the gastric fornix. So it is very difficult, and endoscopic maneuverability is unstable. And this location is the final location. I think to achieve the success ESD, first, precise diagnosis is essential, especially for the tumor border. So in this situation, please use NBI magnification and injibocalmide in the comprehensive manner. And next, before ESD, please master and please get the knowledge of the various ESD knife. And first, I recommend please master one device. And after about 30 cases, if you feel some difficulty, please change the others. And before you use the new device, please get the knowledge from the hands-on seminar or live demonstration. And ANBIIG program help you such a situation. And before the treatment, please master the basic strategy of the ESD. And the last one, ESD is team medical care. Yeah, please communicate with your young colleague or nurse or assistant well. Maybe if you can do this one, you can get to achieve successful ESD, and you can get the lesion in embryonic fraction without any complication. Thank you very much.